Hello everyone, I'm Dr. Natisha Arora from Fortis Escorts Heart Institute, New Delhi, India. Today we'll be discussing a very interesting case of tuberculous pericardial abscess from cardiac radiology. The history is of a 26-year-old man from South Africa presenting with shortness of breath, chest heaviness and low-grade fever for 10 days. Next we did was a contrast-enhanced chest CT. On the given slide are the non-contrast images which shows both the axial as well as the sagittal sections of a well-defined hypoattenuating lesion. The mean attenuation was around 30 HU within the pericardium. So this was the lesion within the pericardium. You can also see that not only the wall of the lesion is thickened in the pericardium, but also that the pericardium is diffusely thickened. It is also showing an irregular thickening. The pericardial collection posteriorly also compresses the right atrium and the right ventricle. The coronal non-contrast chest CT, it shows some small calcified mediastinal and also right hilar lymph nodes. You can see very well the calcification within these lymph nodes. On the given slide are the early contrast-enhanced chest CT images, axial as well as the sagittal sections, which again shows a very well-defined hypoattenuating pericardial lesion as depicted by the yellow arrows with a peripheral rim enhancement. You can see that there is some peripheral rim enhancement and mass effect was seen on the right coronary artery. This is the right coronary artery in the right AV groove. There is a close relationship of this lesion to the right coronary artery. So these are the axial delayed contrast chest CT images. The lesion can be very well depicted over here, and more importantly is that the pericardium, the thickening of the pericardium is very well appreciated on the delayed images. It is not only thickened but it is also enhancing. So based on the above imaging features, our final diagnosis was of a pericardial abscess. It was a well-organized pericardial collection with thick enhancing rim with attenuation more than simple fluid, suggesting exudative pericardial effusion. The pericardium is diffusely thickened and it enhances homogeneously following contrast administration, which was consistent with pericarditis. Given the patient's signs and symptoms of infection, this is most consistent with pericardial abscess. Histopathology and cultures confirmed later a pericardial abscess which was caused by Mycobacterium tuberculosis. So our first differential diagnosis was of a pericardial cyst, which is also commonly found in this location, that is in the right cardiophrenic space. Pericardial cysts are congenital and usually adjacent to right atrium, well defined, and they are non-enhancing lesion, but they have fluid attenuation. In our case, the attenuation was slightly more than that of fluid, around 30 HU. The second differential was of a loculated pericardial effusion. Simple pericardial effusion, they have an attenuation which is also approximately of the water density. Plus, the thickened and the enhancing wall, it suggests an alternative diagnosis in our case. Our third differential diagnosis was of pericardial neoplasm. So primary neoplasms rarely manifest as a cystic mass due to necrosis. Enhancement is generally heterogeneous due to solid components. So the take-home message was pericardial abscess may form secondarily due to localization of pericardial inflammation with adhesions, fibrosis and pus accumulation. Cross-sectional imaging with CT and MR accurately demonstrates the anatomy of pericardium and is superior to echocardiography in evaluation of extent of focal or generalized pericardial lesions and effect on adjacent mediastinal structures. A pericardial abscess has higher CT attenuation than simple fluid. Additional imaging features include diffuse thickening or calcification of pericardium and adjacent inflammatory fat stranding. MRI adds diagnostic confidence by characterizing nature of abscess cavity. The contents are usually high signal intensity on T1 weighted images due to high proteinaceous content indicating an exudate. T2 signal intensity varies depending upon histopathology. Management consists of drainage and antituberculous drugs. Pericardiectomy may be used with associated constrictive physiology.